Hi everyone, my name's Rohan. I'm one of the core medical trainees here in Nottingham from the East Midlands region. What we're doing here is we're creating a set of videos to help prepare for the PACES examination. We'll be covering in the different videos series stations 1 to 5, and we'll be covering practical tips that you couldn't get from books, that we've learned from expert acumen and the many years of experience from expert examiners. And basically what things we'll be covering, for example, in the individual stations would be things like common tips, common pitfalls, and common things that get asked in the examination. So we're going to start off with station 1, covering the respiratory and the abdominal parts, and later examinations will be covering the various other stations. Thank you very much, Dr. Subramanian, for agreeing to do this PACES video for us.
It's a pleasure, Rohan.
No problem. So today we'll be covering 2 stations of PACES. We'll be covering station 1 and station 3. And what we'll be covering is basically tips for these particular exams, common pitfalls, and just pearls of wisdom.
So the first thing you need to remember is we as examiners are there to help you. We're not there to fail you. We want you to pass, because we want you to go up the ladder and become consultants in the near future. So the first thing to remember is, if we are saying, can you focus on certain thing, do that. Because we are not going to try and point you in the wrong direction. The next thing you need to do is read the question carefully. You don't need to just go in there and start examining straight away. Read the question carefully and look around the patient. Take a few seconds, it doesn't matter. You are used to examining. So take some time first. The third thing to remember, the basic thing to remember, is you need to practice before the exam. Because if you haven't practiced examination skills, then when you're examining the exam, you're actually thinking, what am I going to do next, rather than what am I finding now. So you need to be in the now rather than what am I going to do next. So the more you practice, it becomes second nature to you, and you can start examining, start looking for the findings at that stage. The next thing you need to remember is, in most instances, and 99.9% of the instances, you will not have a patient who is acutely ill. So if you're going to think about endocarditis, they're not going to be acute infective endocarditis because they are really ill. So remember that. So if you are looking at respiratory station, it's quite straightforward to think about. There are certain cases you would get. So you're not going to get random cases. You're going to get cases which are pretty straightforward, generally have very good clinical signs. Common things you get is somebody who is stable. So if they've had a lung transplant or an immunectomy, they are stable, so they keep coming back and forth to the exam. The second is pulmonary fibrosis. They're very common. You do get COPDs on a regular basis, and bronchiectasis is a common thing as well. So bronchiectasis or cystic fibrosis, depending on the age group you're looking at and what other stuff they have around them. So if they are PEG-FED, for example, you know they've got CF and not pure bronchiectasis. So these are the common kind of stuff. You're not going to get lung cancer. Pleural effusion is quite rare actually, because if you think about it, they are malignant pleural effusions, they rapidly decline. So you're not going to get them. And we won't keep a pleural effusion from heart failure in the respiratory station. So just remember that. While you're examining, one of the common things I find is actually ask the patient to turn around. If you don't do that, you can very easily miss small scars like VATS or even sometimes thoracotomy scar in the back. So it's quite important. You don't hook around the patient and make yourself uncomfortable. Just ask the patient to turn around. So generally what I tend to teach the candidates is inspect the front, palpate the front, auscultate the front. You don't need to do vocal fremiters because you're doing vocal resonance anyway. That's far superior. Once you have done that, ask the patient to swing their legs around to the other side of the bed so you are behind the patient. It's easier for you to feel the neck for the lymph nodes, and then it's much easier for you to inspect the back as well and examine the back comfortably. If they are leaning forward, you are uncomfortable, patient is uncomfortable, particularly if they've got significant breathlessness, the patient is going to really struggle leaning forward. So turn them around. It makes it easy for everybody.
Great. Just a quick question about exposure for the respiratory station in terms of how much, when to do it, and if it changes between gender.
In a respiratory system, it's probably best to expose as soon as you walk into the room. Introduce yourself, ask permission whether you can examine, and then say, would you mind taking your top off? Whether it is a man or a woman, you need to expose fully. So you do need to ask the woman to take the bra off, assuming that's acceptable with her. Generally speaking, in an exam, when patients come in, they know they need to take the bra off, so they won't say, no, I won't. However, one of the important things to remember, the difference between the two genders is, once you have finished examining the front anterior aspect of the chest, as you move to the posterior aspect of the chest, as you ask the patient to swing their legs round so that you can see the back well, you may want to ask the lady, do you want to put your bra back on to cover the front? It's probably worth. She may or may not say, yes, I want to, but that doesn't matter. At least as an examiner, I know you're trying to preserve the dignity as much as possible.
So you were saying with the common, one of the potential examples is a lung transplant. What exactly would you expect to find with a patient with a lung transplant?
So that's a very good question. Generally speaking, if you see somebody who has had pneumonectomy for malignancy, for example, you see a thoracotomy scar on one side, but you're usually doing lung transplant for somebody like CF, in which case, first of all, you would see them from a distance as you walk in. So you're going to see, have they got peg feeds, or are they looking very thin, loss of weight and stuff like that. So that might give you some idea. The second thing that might give you an idea is, because of the lung transplant, they're going to be on immunosuppressants. So it might be steroids or whatever else they're going to be on. So you might see some of those features straight away. The other thing you would see is, you would see scars on both sides, because they're going to have removed both lungs, otherwise they keep getting infection from the CF lung. So you would see scars on both sides. On the side of the transplant itself, it could be completely normal. You might hear some crackles, depending on what else is going on, but generally it can be completely normal as well. So if you see somebody who's got normal air entry, normal chest expansion, normal breath sounds in one side, and they're scarred in one side, then it's likely they've had pneumonectomy on the contralateral side. But if there's scar on both sides, think, have they had lung transplant?
And so we'd expect on the other side for it to be reduced breath sounds completely?
Yes, yeah, you would see features of the mediastinum might be shifted to that side, both the upper and lower mediastinum. There would be no air entry, there would be very reduced expansion. So they are common signs, obviously, with pneumonectomy as well.
On the note about examinations, is it better to present as you go along, or is it better to just examine your patient and then present at the end?
As an examiner, it does not matter to me. If you're talking it through, I'm not bothered about it. It is quite important, though, you need to tell the patient what you're going to do. In fact, when you do that, many times you're talking through what you're doing anyway. Because you're going to say, now I'm going to just have a feel of how your chest expands, for example. So you know what you're doing at that stage. However, when you come to presenting your findings, I will always ask you, what did you find on examination, irrespective of what you had said during your examination. Because I want to make sure you are putting them all together, rather than just random pieces of information. So it doesn't matter whether you speak or not. Some people prefer to talk because it makes them less nervous while in the exam, particularly if you're starting with station 1. Some people just carry on with examining. It doesn't matter whatever you do.
So when we are presenting back to the examiner, how best would you say, in your opinion, is to present? It
depends on what the question is asked to you. So again, once again, it's important to listen to what is going on and what the examiner is telling you. If the diagnosis is pretty straightforward, most of the time what we'll say is, what do you think is going on? in which case you say, I think this patient has got X, Y, and Z because of such and such findings. If it is not that clear-cut, it may not be the case in the respiratory system, but it could be in other systems. If it is not particularly in neurology, when it is not very clear-cut, we ask you, so what did you find on examining this patient? In which case you tell the findings. It is crucially important you mention both the positive and significant negative findings. Say, for example, if somebody presents with increasing difficulty walking in a neurology system, then it's quite important to say this person does not have fasciculations, for example, because MND might well be the reason why they can't walk, but that's a significant negative findings. Whereas going back to your respiratory system, it's probably worth saying the patient is not tachypnic, but more importantly, it's worth saying this person does not have features of carpulmonality, because that's a significant finding. That alters how you're going to manage the patient. So any negative finding which might change your management or change your diagnosis needs to be mentioned.
And on that note, which would you say are the top respiratory ones to make sure you absolutely, top negative findings to absolutely make sure you include?
I guess probably three important things. You need to mention about, have they got features of cyanosis, central cyanosis? Have they got carpulmonale? And are there any scars? Because they all make a big difference in terms of diagnosis. Sometimes it might be just a chest drain scar, but that is quite important to know because they have had some problem in the past. So realistically, those are the three major things you need to mention.
So on that note, could you give us examples of how to present respiratory stations?
So I could perhaps start with how not to do a presentation to start with.
Great.
Assume you have a patient with COPD and he's cyanotic. He's not cyanotic, let's say. He's not cyanotic, has got features of carpulmonale, and possibly has had lung volume reduction surgery. Okay, so you're going to see some scars. This guy is not cyanotic, but he has got carpulmonale. So how not to present is, this patient has got, to start with, you need to get the diagnosis right. Have you come across something called double jeopardy?
Yes, in America.
No, in PACES exam. So double jeopardy is, you can talk all about the investigations and management quite appropriately for a diagnosis you have made, but that diagnosis is wrong. Then you don't score anything in that either, in the investigation management sections either. So if you don't get the diagnosis right, you lose every point after that, irrespective of how good you are. So it's quite important to get the diagnosis right. So instead, say for example, this person mistakes that lung volume reduction surgery and COPD for pneumonectomy. A bad way of presenting is, this patient is not cyanosed, this patient's chest expansion is reduced in all quadrants. There's reduced artery bilaterally, but more so on the right side. There's a scar on the right side, which I think is a thoracotomy scar, and in my opinion, this patient has had a right pneumonectomy for probable lung cancer. Completely forgetting the fact this patient has got hyperexpanded chest, has got carpulmonale, and all the other things. Because if you don't pick the hyperexpanded chest, you're going to miss a lot of other findings. Whereas a good way to present that is, this gentleman has got evidence of carpulmonale, there is no evidence of cyanosis, he's tachypnic at rest, the lung expansion is reduced on all sides, he has got a scar on the right side posteriorly. My view is, this gentleman has got COPD. Given that he has got COPD, it's likely he was a smoker. I can't work out why he has got a scar in the back of his chest. It might be for lung volume reduction surgery, or it might be that he had malignancy, bronchial malignancy, for which he was operated upon. That tells me, as an examiner, you're actually thinking through what you've found rather than just having a scattergun kind of approach. So you've found the diagnosis of COPD. For me, that'll give you extra points for for you as a candidate, because you've found this patient has got COPD, you've found this patient is breathless, carpal so you're looking at potentially long-term oxygen therapy and what else you need to do. You've found this guy has had scar, so you know from COPD he was a smoker. Chronic asthma could lead on to COPD, but by far the commonest is smoking. Yeah. And as a smoker, he's at risk of lung cancer. So if, for example, if the instruction in the station says this patient presents with breathlessness, examine the respiratory system, you're already thinking, is the breathlessness due to carpal and lung function going down? Is it because he has had surgery due to lung cancer and his reserve was already limited, so he's getting worse? Or is there any evidence of recurrence of lung cancer? So you're looking at all those, whether you say it or not.
Which
recurrence of lung cancer?
Recurrence, yeah.
Because he could have another lung cancer. So even though you don't tell me those, I know you've been thinking about all those. Then I can go on to explore further, and I'll give you a clue at that time. So if you think he has had lung cancer surgery, what else might be making him breathless? So he might have radiotherapy, for example. So you can start building more and more. It's like building blocks. If you don't have a good foundation, it's not going to stack up later on.
Great. Well, so that's a really good example of how to present a case where the findings or the diagnosis is not 100% clear. So could you give us an example of how to present a case where actually the diagnosis is a bit more straightforward?
So let's take an example of bronchiectasis. When you see somebody with bronchiectasis, one, you might see pots of sputum around. You're going to hear coarse crackles, either on one side or both sides. And generally speaking, a lot of people with bronchiectasis will have clubbing as well. So in which case, I would start with, first of all, you're hearing crackles on listening to the chest. So you need to differentiate whether it is a fine end respiratory crackles or it is coarse crackles, which is not changed by coughing. Once you've done that, then you're looking for other signs. So if I was presenting somebody with bronchiectasis, I would say, this patient has got bronchiectasis. The patient is comfortable at rest, or tachypneic, depending on what it is, because that's quite important. Is comfortable at rest, has got features of finger clubbing, and on auscultating the chest, there are coarse crackles in the left base or in both bases. I do note that there's a sputum pot as well, and the lung expansion has been normal bilaterally, which tells me you've looked at pulmonary fibrosis, because obviously there's going to be variable expansion in that, whereas in bronchiectasis generally the expansion is pretty normal. So you could say that and say, that's why I think it's bronchiectasis. You could argue, you could say the findings first and then the diagnosis, but if you know the diagnosis, go with a punch and say, that's a diagnosis, it is supported by my findings of such and such.
Great, thank you. And just a quick follow-up to that question, when you said, just as a clinical point, so you said with patients who have pulmonary fibrosis, that there is reduced expansion. Could you just explain that a bit more?
If you are taking the case of pulmonary fibrosis, as you know, there are some conditions which affect predominantly the lower lobes, some affect predominantly the upper lobes. So let's take a classic example of interstitial lung disease, CFA, who have clubbing and pulmonary fibrosis features. It affects both sides, but then it affects predominantly the lower lobes. It doesn't affect upper lobes earlier on. It's much later when you start getting generalized features. So the expansion tends to be normal, more or less normal in the upper lobes, whereas in the lower lobes it tends to be much lesser. So in terms of examination itself, if you look at the upper quadrant posteriorly, it'll be reasonably normal. Yes, it might be reduced, there's no question about it. Whereas when you go to the lower lobe, or the lower quadrant, it's very reduced. And it's usually symmetrical, as you rightly say. Whereas there are times in which, if you have lobectomy, then you know that will be restricted movement on the affected side, or the side of the surgery, but not on the normal side. So it depends on where the difference is. If it is a bilateral disease, it might be between the upper and lower quadrants. If it is a unilateral disease, it will be between the left and right side.
So in fibrosis, could you get a unilateral?
It's exceptionally rare. We are not going to give you something like that. But then the more important thing is to pick out the end respiratory tract holes in that, because that's quite important. That's such a typical kind of thing.
Great. So that was a very thorough overview of how best to present the examination. Obviously, afterwards there comes a bit of management. So how would that go next?
So once you're presented, we ask you, how would you manage this patient? We won't specifically say, how would you investigate? They might say that, but generally speaking, we say, how would you manage the patient? A bad way to answer that question is, I would, for example, in a COPD, I would look at their spirometry and start them on LABA or LAMA. That's bad. You need to know what else is going on. Why are they breathless suddenly? Because a patient has come to you breathless, so it's about investigating. So basic things would be, you need to do spirometry, blood gas transfers, a chest X-ray at least. Sometimes you may need to do a CT scan of the thorax, high-risk CT scan. Sometimes, depending on the history, if I tell you, for example, I want to guide you towards bronchial malignancy, on top of COPD, I'll say, okay, doctor, if the patient had said he had had a couple of episodes of hemoptysis 3 weeks ago, what would you do? Then you would be heading towards bronchoscopy and biopsy potentially. So you need to mention the investigations first. On the other hand, if it is going to be pulmonary fibrosis, you want to know their effort tolerance, how far can they walk before they get breathless, because clinically they might be getting worse even if the pulmonary function is stable. But you certainly need pulmonary function tests. You certainly need high-risk CT. If they haven't got a diagnosis of what type of interstitial lung disease it is, then you may need a transbronchial or even a VAT-assisted biopsy. So you need to mention all those. When it comes to treatment, that's slightly different. We want you to tell us the principles of management. I'm not expecting you to tell me the doses of the LAMA inhalers or LABA inhalers. I'm not bothered about that. I want you to tell me the principles of management. So I will start them normally on an inhaled bronchodilator. If they're still getting symptoms, then I would think about a LAMA. If they're still getting symptoms, I would get a LABA. And if they're still having problems, then I need to think about a respiratory opinion. Because we don't expect you to be a specialist in that. We want you to be a generalist who can deal with general kind of problems rather than being a specialist of how to manage severe COPD kind of stuff.
So thank you so much. That was a great overview of the respiratory examination as part of Station 1.
It's a pleasure.